Today we shall learn about supraclavicular brachial plexus block. It is also called as spinal anesthesia of upper limb because the block is so dense that you need very minimal sedation after you give this block, and it is the block is given at the level of the trunks of the brachial plexus. So this is the Medlogix company SenStim nerve stimulator, which is used for peripheral nerve blocks. It has got a positive lead and a negative lead, and this is the insulated nerve stimulator needle of B. Braun company. It has got a white wire, and also this is the transparent tubing which is used for the injection port. This positive lead is attached to this white wire of the nerve stimulator needle. So now coming to the indications. So supraclavicular brachial plexus block is indicated for all surgeries below the level of the shoulder we can give. So at the level of the shoulder you need interscalene block. So the contraindications are commonly like infection at the local site, coagulopathy, contralateral lung disease and contralateral phrenic neuropalsy, because the incidence of pneumothorax is around 0.5 to 6% with supraclavicular brachial plexus block. So whenever patient is having a contralateral lung disease, the respiratory embarrassment and patient may have difficulty in breathing. So that is why this it is contraindicated in patients with contralateral lung disease. And also this phrenic neuropalsy, the incidence of phrenic neuropalsy is more than 50% with supraclavicular block. So that is why whenever patient is having contralateral phrenic neuropalsy, it is contraindicated, and also bilateral supraclavicular block is contraindicated. And of course patient refusal is also a contraindication. So here you can see the anatomy of the brachial plexus in the supraclavicular area. So here this is the subclavian artery and this is the brachial plexus. The trunks of the brachial plexus are placed within the sheath of the subclavian artery. So these trunks are placed posterior and lateral to the subclavian artery. So here this is here we can see this is the first rib. So this first rib it acts on the inner side of the first rib we have got the apex of the lung. So while inserting the needle we should remember that we should not go too medially, that is we should not go medial to the lateral head of the, that is the clavicular head of the sternocleidomastoid. The needle should not go medial to the clavicular head of the sternocleidomastoid, and we should not go towards the medial side of the first rib. So because in order to prevent pneumothorax. So initially with a current of 1 milliampere set on the machine, we have to insert the needle posterolateral to the subclavian artery and directed in a corded medial and posterior direction, and we have to seek further extensor or flexor response of the fingers. And we should remember, this is very important, a drug should not be given when there is shoulder muscle contractions because that will result in failure of block. So always remember the extensor or flexor response of the fingers. At that point only we have to give the drug. And this response of the fingers, it should be present at less than 0.5 milliamperes. Sometimes what happens is even at 0.25 milliamperes also the muscle contractions will be visible in few patients. This indicates intraneural placement of the needle and the needle has to be withdrawn. So always remember, in order to prevent intraneural injection, it should be there should be absence of muscle contractions at less than 0.3 milliamperes. And we have to give the local anesthetic solution after negative aspiration for blood. So how can you prevent this nerve injury during supraclavicular brachial plexus block is one is you have to prevent giving the drug when there are muscle contractions at less than 0.3 milliamperes, and whenever the pressure is too high on the plunger of the syringe. When the pressure is more than 15 psi, it indicates high pressure and intraneural placement of the needle. And one more thing is, patient complains of severe shooting pain along the distribution of the nerve when you give the intraneural injection. So by knowing these 3 points, you can prevent this intraneural injection of the drug and also prevent nerve injury. So here you can see the contraction of the finger muscles. So it is at around even 0.23 milliamperes also there are contractions of muscles is seen. So here we should not give the injection because the needle is very in close proximity to the, it is, mostly it's a intraneural placement of the needle. So we have to slightly withdraw the needle. So there should not be any contractions at less than 0.25 to 0.3 milliamperes. So when there are no contractions at less than 0.3 milliamperes, so then we can give the injection. So here when I am decreasing it to 0.3 milliamperes, still now also the contractions are seen. I am withdrawing the needle a little bit outside. So here the contractions are not seen. Now after increasing this thing, the current to 0.45 milliamperes, the contractions are seen. Now after aspiration for blood, we will give the injection. So even by giving 1 ml of local anesthesia, we can see a supraclavicular brachial plexus block in a 4-year-old child who is posted for K-wire fixation for supracondylar fracture. Okay. So here initially the current started with the 1 milliamperes, and then you have to see for the contraction of the fingers, either the extensors or the flexors of the fingers. So gradually the current is decreased. So that when there are contraction of the fingers is seen at less than 0.5 milliamperes. So here now you can see the contraction of the fingers at least 0.49 milliamperes. Now we can do the injection.